Hello everyone, I am Dr. Vivek Mahajan. I am Senior Consultant in Joint Preservation, Arthroscopy and Computer Assisted Joint Replacement, and I am working at Indian Spinal Injury Center, New Delhi. Let's talk about the meniscus repair. If you look at the literature comparing the outcomes of meniscus repair with the meniscectomy, then the literature shows that meniscus repair has a much better prognosis in the long run. With this in mind, so today we'll be talking about the meniscus repair. Let's first talk about the anatomy of the meniscus. Meniscus, there are two semilunar crescent fibrocartilages which are present in the medial and the lateral tibiofemoral compartment. Medial meniscus occupies almost like 60 to 65% of the tibial plateau, whereas the lateral meniscus, it occupies the 80 to 85% of the plateau. They are made up of collagen fibers which are arranged circumferentially. If you talk about the medial meniscus, it's a wider C as compared to the lateral meniscus, and it is attached to the medial collateral ligament and it is more attached to the capsule. However, the lateral meniscus is not attached to the lateral collateral ligament and it is more mobile due to lesser capsular attachments. The blood supply of the meniscus, it comes from the periphery through the genicular vessels branches, and almost like 25 to 30% of the peripheral meniscus is vascular. That's why we divide the meniscus tears into red zone, which is a vascular zone, red-white zone, and a white zone, which is a avascular zone. Whenever you get a meniscus tear, usually the mechanism of injury is flexion of the knee, and then there's a tibial femoral compression and it is combined with the rotation. All these together can cause the meniscus tear. If we talk about the types or the classification of meniscus tear, usually it's a longitudinal tear which, if unattended, can lead to a bucket handle tear, or there is a radial tear which can progress to a parrot beak tear or a complex tear, or there is a horizontal tear which can progress to the flap tear. Nowadays, we also talk about the root tear, which on MRI are seen as meniscus if it is extruded more than 3 millimeters, or there is a ghost sign on MRI. Then there are ramp lesions which are present almost in 70% of the ACL tears, and they are commonly missed because there is a posteromedial blind spot while using the anteromedial or the anterolateral portals during routine knee arthroscopy. If you do the meniscectomy, let's say if you are doing a total meniscectomy for a bucket handle tear or a complex tear, then you are decreasing the joint contact area by almost 75%, and you are increasing the peak local contact pressure by almost 200%. This causes the overload of cartilage, which eventually loads the subchondral bone and leading on to the early onset of osteoarthritis. Long-term results of total meniscectomy shows that virtually all these patients, they develop early osteoarthritis, which is proportional to the amount of meniscus which has been resected, and prognosis is much worse in younger patients.